I'm a faculty with Texas A&M. My lab is in IBT, and originally we normally do mechanistic studies, but on the translation side of it, we're interested in cancer prevention. So one of the topics that we're working on is to treat in a non-invasive way all premalignant lesions as a way to prevent the occurrence of oral cancer. So oral cancer is our biological objective, how to prevent that happening. And oral cancer is not a very common disease. It's 8th in the men and 15th in the women. But the problem associated with oral cancer is that there's a very high the survival rate 5 years is very low. It's only about 50% compared to other more common cancer like breast cancer or prostate cancer that sometimes can achieve about 80% survival rate. And in addition, the patient that receive treatment, even though they survive the disease, but often left with a very severe consequence of disfigurations in the mouth area. So as a result of that, they have problems with swallowing, speaking, or drinking, and also with problem with appearance. So it becomes a major problem. It's a bad problem, in combination of this outcome as well as the low mortality, high mortality rate. The silver lining behind the oral cancer is that is visible from outside. Almost always develop from precancerous lesion, and those precancerous lesion is visible from outside. It's often detected by dentists during the regular dental exam. But the issue with that is for the oral premalignant lesions, depending on the pathology, low grade has 4 to 10% of malignant rate lifetime, and high grade has 1/3 of the chance of becoming cancer. So the chance of malignant transformations for premalignant lesion is significant, but still a minority of the cases. So therefore, that presents a problem. If you start treating everybody with low-grade cancer, then you're over-treating the 90% of the patient. And considering the consequence of the treatment, as I said before, with laser or surgery, that you're often left with severe scar formation, then that becomes an issue, whether 10% or 4% is large enough to consider those consequences, even though you have probably 95% of not actually getting cancer in the end. So what we're trying to do is develop a non-invasive method based on drugs to see whether we can mitigate the premalignant lesions so that the patient can be treated more widely without incurring severe consequences associated with surgery or a laser. Especially for oral premalignant lesions shown in the middle pictures, that is more diffuse or multiple. In that case, if you start doing surgery or laser, you're bound to affect a large surface of the tongue and cause a major side effect of the treatment. So therefore, a non-invasive method would be ideal in this case. And for this reason, there's no standard of treatment for oral premalignant lesion up to this date. So on the drug-based side of it, we're using a combination of 2 drugs. One is oxaliplatin, the other is mycophenolic acid. And the inclusions of mycophenolic acid in treating premalignant lesion is based on our mechanistic study on stem cell mechanism. So I won't go into detail about that. But what we found is that mycophenolic acid, which is used as a prophylactic for organ rejections, can be used as a chemosensitizer to sensitize chemotherapeutic agents to kill certain type of cancer or precancerous lesion based on the combination. So a specific combination with oxaliplatin kills oral premalignant lesions cells as well as oral cancer cells significantly, shown here on the right side. The top one is the cancer cell line. The bottom one is the precancerous cell line. And the combination with oxaliplatin with mycophenolic acid is shown in the right column. The middle column is the different drug combinations. So what we found is that the specific combinations, mycophenolic acid with oxaliplatin, can synergistically kill both the cancer cells shown on top, A3, as well as the precancerous cells in B3. So that is our drug basis for this device. So the question now is how to deliver those combination of drugs in a controlled manner onto the lesion site. The issue with mycophenolic acid used systemically is that it's metabolized in the liver. So therefore, it becomes inactive over time for the cancers. So therefore, it's not being used for cancer treatment. And for oxaliplatin, although it's a very effective anti-cancer drug, it has a very high neurotoxic effect. So therefore, it limits its use systemically. Now, if we combine them together into a topical delivery format, then we can circumvent those problems for both mycophenolic acid and oxaliplatin. So therefore, that's what we're thinking. Combine them, embed it in a way that they can be released in the right ratios onto the topical lesions, that is before cancer. In that case, we can avoid the systemic metabolic effect as well as the systemic toxicity effect. At the same time, we can treat the lesions topically. So what we do is using a patch design. We use the patch design because the patch allows the drug delivery in a directional manner with controlled release profiles. So that's what we use. And we're collaborating with bioengineer in using the 3D computer-aided design printing to embed those drugs into a bioadhesive layer that's shown in the yellow part onto a supporting layer that's shown in the gray. And after we formulate the patch, we use the in vitro drug release profile to optimize it. So we're looking at the profile of the drug release in a ratio that's consistent with their molar ratios of 1:1, as close as possible on one hand. On the other hand, has achieved a sustained release over the period of 1 to 4 hours, so to speak. So after rounds of trials, up to 7 generations or 8 generations of patch formulations, what we reach is this type of in vitro drug release profile. On the A panel is the drug release profile for oxaliplatin. And we can see that oxaliplatin in the different slight variations of formulation can achieve a sustained release over the period of 4 hours up to the extent of about 90% of the embedded drugs. So especially for the green line that represent one type of format. For the mycophenolic acid, is a more stable drugs, and the release is more sustained, almost like a zero-order release format. And over the period of 4 hours is linearly released, but only achieve about 50%. But in combinations, those two drugs in the green format allowed us to achieve a weight ratio of 6:1 mycophenolic acid to oxaliplatin, and that's equivalent to the moiety of 1:1. So that's why we think this formulation maybe is good for our remaining test of this patch, especially for the in vivo drug release as well as the in vivo efficacy study. So we also tested a few things regarding the patch property. On the A panel is the stability assay. The left one is oxaliplatin, and then the right one is mycophenolic acid. And mycophenolic acid is pretty stable at different temperatures, 4 degrees, minus 20 degrees, or 25 degrees over a period of 1 month. Oxaliplatin is very unstable at room temperature, but at 4 degrees or below is relatively stable over the period of 1 month. And the B panel shows the tensile strengths testing, the in vitro mechanical. So we stretch the patch using the texture analyzer, looking at the patch resistance to the force as well as how well they stretch. So the representative force parameter is the megapascal. It's about 2.4 for the patch, and that falls within the same tensile strength as the mucosa. So that's compatible with the site that the patch is applied to. So we're happy with that. And next, we test how well the patch adhere to the mucosa. One is the in vitro part, so we put the patch ex vivo onto a tongue and then immerse it in artificial saliva over a period of 4 hours, so they're totally immersed in the artificial saliva. So in that situations, over the period of 2 hours, about 50% still stay. Over the period of 4 hours, most of the patch detached because essentially the tongue is floating inside of the fluid. And that's the ex vivo attachment. And next we test the in vivo attachment of the patch by putting the patch in the front dorsal side of the tongue, showing A, the left panels, or posterior side of the tongue in the middle part, or on the buccal mucosa. And we put different sizes of the patch over a period of time between half an hour up to 4 hours. So lo and behold, most of the patch stays in the in vivo conditions where there's no mouth full of saliva. So this mostly just one attachment. The side that's attached is moisturized, but the surface side, the air side, is not immersed in fluid. So therefore, it stays better for the in vivo part. So for the one last size, I show some preliminary data that we look at the in vivo drug release. So we don't have the complete data yet, but this is a profile that we get. On the A panels, we assay the mycophenolic acid release in the tongue tissue after we apply the patch on top of the tongue from 1 hour to 4 hours. And the B is the oxaliplatin amount. So what we get is, by applying the patch on the tongue for 4 hours, we can achieve a stable tissue level of mycophenolic acid. But for the oxaliplatin, it actually, in the first half an hour, it reached the most and then drop after an hour. And, maintain at about 1/3 of the level over the period of, 1 hour to 3 hours, and then drop off after we take off the patch. In the C panels, it shows that the blood absorption during that 4-hour period of time. So after we apply the patch, take it off, in 8 hours, the amount of drug in the blood increased, but after that, the amount decreased. But we cannot detect any oxaliplatin in the blood during this process. So all this drug release assay, the MS assay, is all thanks to Dr. Liang and Dr. Xie's expertise, and as well as the Yang and Xiu Juns in the audience, their help. So I just want to thank again, the people that work for me, and also, Xiu Qing and Yang in the audience working for Dr. Liang and Dr. Xie, as well as my collaborator at the Baylor College of Dentistry, Dr. Xiaohua Liu, bioengineer, and also my oral pathologist collaborator, Dr. Chen, also in Baylor College of Dentistry, and Chang Li is a postdoc working with Xiaohua. They're all the people that are making this possible. So, and also, never forget my funding, CPRIT extra grant, as well as the CPRIT funding to CFSA.